All right. Because Liam asked a question about like the difference between, where are we? Basal lamina and basal linear. So we often use the term basal lamina for the basement membrane of a thing. Right, so here's Brooks membrane, which has got multiple layers in it. The most inner one is the RPE basement membrane. And then there's the collagenous zones, etc., etc., and then the choroid basement membrane through here. And I have to confess that I don't actually know which of these layers gives rise to drusen. Do you know? I was just going to find it out. Now, do you know, Amanda, which of these layers gives rise to drusen? Does anyone else know which of these layers gives rise to drusen? No.
Yeah.
So I will have to look that up. But I always thought it was this bit here, the RPE basement membrane, that gave rise to them, but I couldn't tell you for sure that it wasn't the choroid basement membrane. So that's something I will have to learn. Oh, are they telling us stuff? Here we go. Henry is giving us well, Matt says the basal linear is within Brooks, external to the RPE. I think you guys know more about the histology of the Brooks membrane than we do.
Because we can't tell the difference on histology. It's
the basal. So do you mean basal lamina, Matt, or is it really basal linear?
No, the two sort of terms and egos for the sort of types of drusen. I mean, soft drusen they say is lost during processing, but they distinguish between this sort of theoretical basal linear and basal laminar drusen, and then you obviously have hard drusen as well. I mean, I know it's sort of it's not relevant to sort of your practice, but I think the theory they just make that distinction. Yeah. At the end of the day, it's all drusen.
Difference.
All right. So yeah, we've got a thing from Henry from AAO. First detectable pathologic changes between the basement membrane of the RPE. That must be the yellow one, and the basal and the elastic portion of Brooks membrane. So I don't know, maybe in here.
Yeah, and they argue that the basal laminar, because it attaches loosely to Brooks, it's that plane for neovascularization.
All right. Basal laminar plasma membrane RPE. I still think I need to read about this a bit more.
If you zoom out, the middle zone there is the elastic zone. So basal laminar, I remember, because A is apical, so basal laminar is closer to the basement membrane of the RPE between the RPE and the elastic, and then linear is deeper in the retina, which is, sorry, yeah.
So the green one's the basal linear, and the yellow one's the basal laminar.
To see that level of detail, you need an electron microscope.
You do need an EM, yeah.
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 Which we don't have for routine diagnostic purpose. It's a research tool.
Yeah, anyway, yes, sorry we didn't know that.
I think we don't need to know that.
All right, we're back to our schedule here. All right, so here we go. We're looking at the skin now. So the skin is a vast topic of which you only really have to know some principles. So in your pre-work, we had this presentation about how to examine a slide. And then down here on page, I'll just let it load a minute. On page 16 or 17 was how to look at skin. All right. So the first thing is, where is the abnormality? So that means first recognizing what is normal and where is the abnormality. And in particular, you look, is the abnormality an epidermal abnormality, a dermal abnormality, or a junctional abnormality? It's an epidermal abnormality. We're talking about things that are in situ, and it's usually squamous. If it's in the dermis, right, so we've got cells extending into the dermis, then we can, next thing we ask is what kind of cells are they? And the most common cells that you're going to see are going to be nevus cells, basal cells in BCC, or invasive SCC. And then we look and see if the cells are benign or malignant. And then we kind of pull back a bit and say, do your other observations support your diagnosis? So for example, if you have a set of cells that is in the dermis and it looks horribly malignant, right? And it's producing pigments, then you can easily put 2 and 2 together. Producing keratin, put 2 and 2 together. Okay, so looking for specific clues as to what they are, it comes after determining where they are and whether they're malignant. So you need to be able to recognize the basic cell types and know the range of diagnostic possibilities. So for example, if you have a papilloma, you need to know the range of diagnostic possibilities of things that are papillomas. And then the cell type, are they basal type or are they squamous type? And to tell you whether it's a squamous papilloma or maybe a seborrheic keratosis. What we're going to do is we're going to leap in and see how you're going. So the pathology registrars will be experts at this because they've seen a lot of skin. They've not seen a lot of non-neoplastic eyes, but they've seen a lot of skin. Hey, Johnny. And so they will be able to help you quite well with this. So I'll put you in breakout rooms again. I'm going to open the same breakout rooms as last time, and we will go for it. So these are going to be fast fire. So I'm going to get you to do 2 at once, okay? Number 1 and number 2 in the schedule, which is, yeah, those little boxes, and they're both from Leeds. I'm hoping that work. Great. Open all rooms. Okay. There we go. So those were two tumors, which were blue tumors below the epidermis, but quite different. So in my group that I was with, people quite easily got to the fact that they were below the epidermis and malignant, but kind of struggled a bit with working out what kind of tumor. Well, they guessed the first one was a BCC pretty well, but what were the clues that tell us which of these blue tumors is which?
Okay, shall I share screen or have we got, or shall Chris and Bridget talk about this one?
You go. All right.
I don't
Or our
mind talking about-
registrars.
I don't mind talking about this one.
Yeah, it's a BBB tumor.
Yeah. Are you going to share your screen, Amanda?
Oh, okay. Yes. You talk me through it, Bridget. It's just coming up now.
So do you want to just put it the right way?
I will, and the one piece is enough, I think.
Okay, so I'll just start talking. So it looks like you've got a portion of skin. You can see epidermis on the top there with adjacent skin adnexal structures with sebaceous glands and a nice hair follicle over there. So it looks like skin. Then when you get to the tumor itself, you can see it's coming off the epidermis. The tumor is forming nice big nodules. You can see at this power an element of retraction artifact with the white clear spaces between the fibrous stroma and the tumor nests or islands. When you go a bit closer onto those tumor islands, there's a bit of peripheral palisading of cells. So that means the cells are lining up around the nodules like a picket fence. And that's a very nice sign for a basal cell carcinoma. In terms of prognostic factors, so this is a nodular basal cell carcinoma, so it hasn't got a micronodular or infiltrative pattern. It looks like the lesion is well clear of the resection margins because you can see the green inked margin at the bottom of the slide. I didn't see any evidence of perineural invasion of the tumor. And in terms of special investigations, for us, this is a spot diagnosis, so we wouldn't be doing any special investigations for this.
Thank you.
Good. Thank
Great.
you. Any questions in our chat? I think it was quite straightforward. I use a good way to remember BBB, blue, below, and I've forgotten this third B. What was the third B? I've forgotten. Basaloid? No, that means blue. I've forgotten. Blue and below, as compared to squamous cell carcinomas, which are pink.
All right. Blue. Liam's suggesting blue below.
Yeah, balls, which are those lobular, blue and ball shapes and below. Yep. Thanks, Liam. Okay, next one. That's cool. Oh, Chris, do you want to talk about it? Shall I?
I can do this one if you can share it.
Yep, I'll bring that one up. It's coming. Share screen. Yes, share. And now I'm sharing this one. I hope.
Right, so we can see skin below, and then this big, at this power it looks bluish, and you can see the skin continues on the other side. These tumors can occur at an eyelid junction, so we've just got to make sure we haven't got conjunctiva on the one edge, but it looks like skin with adnexal structures. If we go to the surface of the tumor, I always like to start at the top to see if it's ulcerating or what it's doing to the surface. There's marked thinning of that epidermis, and I think at this power you can appreciate that there are some nests, particularly as you get towards the edge of the lesion.
Mm-hmm.
Okay, so it's got a nested growth pattern. It's falling a bit apart in the central areas. And if one goes and looks at the tumor itself, it's very cellular. It's got a nested overall pattern, big nuclei, vesicular, abundant mitotic figures and big nucleoli. And then you
Mhm.
see eosinophilic cytoplasm with lots of this brownish pigment. So
That's critical,
that's
isn't it?
probably
Brown
the-
pigment.
So we are dealing with what looks like a malignant tumor causing thinning of the epidermis. It's nested, it's got mitotic activity, and it's forming pigment, so it's consistent with a melanoma.
Mm. So this would be a cutaneous melanoma, is that right? Because we
It
did
looks-
ocular uveal melanomas last week.
Yeah.
So,
This looks like it's arisen in the skin.
and then if we
Um,
go around to the other side
so-
here, sometimes they arise from some
Something,
precursor.
yeah, okay.
don't they?
Some of them are thought to arise in association with a benign component. So if you look at the cells on the right, it's contrast nicely with those on the left. On the right, you've got small, regular, uniform cells with a packeted appearance. So that's a benign intradermal nevus. And then on the left, you've got the melanoma.
Quite a difference, isn't it? And then the whole specimen itself it looks like an eyelid wedge to me, skin on that side, and then coming down here.
Oh,
this
sorry,
looks
that
like,
that is conjunctiva, sorry.
yeah,
I'll look at it, yeah. So it's one that's occurred at the junction of the eyelid margin,
yes,
and you've
which
got
is
some muscle in deep lying there.
muscle there, tarsal plate, meibomium glands,
That's,
yeah, blood, which is traumatic, which came out during the surgery. Yeah, cutaneous melanoma. It's a big one. Oh, here's some more junctional
yeah. Prognostic things are
changes.
ulceration, depth of invasion, mitotic activity. Look for
Yeah,
perineural and lymphovascular space invasion. So it's measured from the top of the granular layer, which is up there, to the deepest point of infiltration into the underlying stroma.
I mean, that's 2 millimeter marker there. So 2, 4, 6, 8. This is very deep, isn't it?
Yeah.
So this is huge. That's a poor prognostic melanoma. So prognostic markers.
Right.
Questions?
Is the white space in the tumor cells on high megs signifying it's poorly adherent, as melanocytes don't like to be close together? So the word for that, Matt, is discohesive. So the cells are becoming discohesive, and discohesiveness can be a feature of melanocytic cells.
Absolutely, because they're not epithelial cells, so they don't have the same intercellular junctions as like squamous epidermis here.
Henry asked, what stains would we do? Well, we know it's a melanoma, so we wouldn't do any of the stains that indicate the cell line. And what we would do would be a Ki-67, because we would want to know the proliferation rate for this.
If it was amelanotic, then perhaps I would consider doing some markers, but this is making melanin. So these are not benign melanin making cells, it's malignant melanin making cells, therefore it's a melanoma.
And the marker that I would choose to show what it was, this would be a SOX10.
To indicate melanocytic differentiation. Oh, what about a BRAF? So Chris, do we do BRAFs on all our cutaneous melanomas?
No, we don't do it on all of them. I know there's a tendency for the deeply invasive melanomas in Australia, they go straight to a BRAF, which enables you to have some treatment modalities. In New Zealand, we tend to do it when they've got metastases.
Yeah, because do you give a BRAF inhibitor for a localized melanoma that's only in the skin that hasn't metastasized?
No, the surgery for that is primarily excisional with adequate margins.
That's right. So, okay, good. I'll stop share.
Great. Let's do the next two. I'm going to open all rooms, and halfway through, I'll give you a little message again. Some of you might have seen the message. Time to move on to the next slide. Okay, how are those?
Excellent. Good
Doing
fun.
okay?
We just had a question at the very last second of how you distinguish upper and lower eyelid in a section.
That's
Why?
hard.
Shouldn't you as surgeons know which one you're
On,
taking?
on the request form.
It's like, how do you tell if the eye is a male or a female? Well, you look at the whole patient.
So maybe you can tell from the tassel plate, but generally I look at the request form.
Surgeon should know.
All right, do you want to run through those quickly, Amanda? I'll share the screen.
Yep. Okay. Let's
Here
do
we
it.
go. Let's do it.
Oh, and let's talk about the difference between skin and conj and how can you tell what's what? That's always a goodie.
I'll
Isn't it?
share the screen. Here, zoom. Share screen.
We've lost Louisa. She's covered her microscope and gone.
She's on call this week, so
Oh, okay. All right, make it big. I think
Sorry.
we'll just look at the right side one. So the first thing to notice that I gave second from the right at the bottom. You can't rotate these ones. Well, I couldn't figure out how to rotate it. Anyway, is the one on the, this is a bisected sample or serial slices through the same sample. And the there's a thick area and there's a frilly rumpled up area underneath. And the reason it's curled around on itself is because the specimen was insufficiently prepared before sending it to the laboratory, causing the distortion of the tissue and difficulty with assessing the margin and assessing a lot of things. So a good exam question is how to send thin, flimsy specimens to the laboratory. And this is a good example of how not to send thin, flimsy specimens to the laboratory because the margins have all wrinkled up. You should send them on some sort of flat mounting thing, on filter paper. It has to be flat before it's fixed. If you just drop the specimen into formalin, it'll shrivel up like a crumpled piece of tissue paper like we've got here.
And as well as margins, we have trouble, you know, is
that invasive? I don't know. No, can't say. So whose fault is that? Or who can fix that? You, the surgeon. So let's have a look at the one on the right. So I'm going to look at the normal tissue first, which is that thin, wrinkly bit at the bottom, which I think are the peripheral margins of the lesion. So that bit there, I think, is the normalish bits. And the question is, now, is this skin or is this conj? Because this could be a skin thing or a conj thing. And I'm looking at it, I don't see any skin adnexy. I don't. I don't see any goblet cells either. But that doesn't bother me because I know that squamous metaplasia occurs in conjunctiva, particularly irritated ones. So that doesn't put me off conjunctiva. I think this is conj. There's probably some solar damage as well. So if I then move to my eyes around and I have a look at this vastly thickened area, it's about 20 times as thick as the conj normally should be. Just at low power, I can see it's a proliferation of similar sorts of cells, and I'm following the basement membrane around, and I can see that it's following the basement membrane. It's got some little stromal papillae into it. I think it looks all in situ to me, and all the proliferation is above the basement membrane. So I'm looking at a dysplasia, and dysplasias would be, you know, the clinical correlate of OSSN. So a conjunctival dysplasia, squamous cells dysplasia of some sort, and I need to grade it now. Is it mild, moderate, or severe? So I need to look a bit closer for that. And does the abnormal cells, these look like squamous cells to me. I can see little intercellular junctions, makes the little prickles. You see the white area in between, like a little pavement. So that tells me this is doing squamous differentiation. I do not need to do a special stain. I know this is squamous differentiation. I can see mitoses very close up to the surface, and I see abnormal cells really all the way up to the surface. So I'd be happy calling this squamous cell carcinoma in situ.
Amanda, what's the difference between CIN3 and squamous cell carcinoma in situ?
It depends which grading system you are using. So the WHO uses a 4-tier grading system, 1, 2, 3, 4. So they have CIN 1, 2, 3, and 4 is squamous cell carcinoma in situ. So WHO is a good one to use. That's what I use. It's got a cervix, for example, other end of the body. It's a high-low grading system. Just depends. What do you use, Diane?
I just use I use a 3 grading system because I think functionally high grade dysplasia is the same as
It is
CIN3.
functionally,
It's the same as squamous cell carcinoma in situ.
yeah. So the important thing is there invasion or not? Because if there is invasion, it's squamous cell carcinoma. And so I drive my eyes all the way along that the stromal epithelial interface to see if there are any little tongues of invasion coming down. And I can't see any, but you see that one on the left, which is all cross-cut? There's that big island there, and that's really hard to interpret because it's been sort of cut on face. I think it's probably not invasive because it's got the lobular architecture is very similar to the ones where I can see where it is cut perpendicular. So I would assess for invasion. If there's no invasion, then I assess for margins. So I'm looking at the right piece again, and I can see there's a little tag of thin conj up there. And if you look closely, there are some goblet cells in that. And then the other one has got a larger margin. So I think the margins are clear. The radial margins are clear, and the deep margin is not applicable because this is in situ. Squamous cell carcinoma in situ / high-grade intraepithelial squamous dysplasia.
So Liam asks, are the darker cells below the basement membrane a lymphocytic infiltrate? And the answer is yes.
Yes,
These cells here are a lymphocytic infiltrate.
yes, host response, very good.
So
And there
what-
was also lymphocytes sprinkled all throughout the epithelium there.
So we do have recordings from a previous session describing the next two, 7 and 8.
Mhm.
5, 6, 7, 8. I think it might be worth quickly us going through.
Oh, we missed one. We missed number 4.
Oh, sorry, missed number 4.
Yeah, that one's quite important because there's, we've been talking about neoplasia all the time, and we sometimes we forget not.
Not neoplasia. There we go.
Yeah. So what have we got here? So is this skin or is this conj is the first question, because I see a surface. It's an epithelial surface. And then do I see skin adnexy? No.
What's
Do
the
I?
next-
Yeah. So, and then looking down in the subepithelial space, I see glandular arrangement there on the left side. They look really like lacrimal gland to me. But then, isn't that a bit odd having lacrimal glands so close to the conj?
Unless they're accessory lacrimal glands.
I think it's probably accessory lacrimal gland, so that's okay. And then the feature of interest is on the right side, which is the big clear spaces. Lipid dissolves out during processing. And so there's lipid space surrounded by inflammatory cells which are whirling around it. And then there's a couple of other ones at the very right edge of the slide, paler areas, which is showing a similar process. So even at this power here, this to me, it looks like a lipogranulomatous pattern. And then I'd go closer and I'd have a look.
All right.
And I'd go and see what it's made up of. So immediately, I'm not thinking of neoplasm. I'm thinking of a reactive and inflammatory process. And yep, clear space. And then what are those cells all? Oh, look at that. There's a multinucleated giant cell hugging this chunk of lipid in the middle. So lipogranulomatous inflammation. I have confirmed my suspicion. And one of those little blobs out to the very extreme right side of the slide shows very nice multinucleated giant cells. Here we go. There, granulomatous inflammation.
So Amanda, how do you know this isn't sarcoidosis?
Well, it's around lipid to start with. So it's
Yeah.
not just granuloma, because my granuloma differential diagnosis is necrotizing, non-necrotizing, but this is lipogranuloma. Typically, we get a bit of tarsal plate because it comes from the meibomium glands, but I don't see the meibomium glands here. They're probably just a little further off the edge of the slide.
Good.
I also wondered about foreign body.
Mm.
Just
just
Yeah,
there.
that little bit.
Biopsy. Yeah.
Yeah. And we're seeing a lot of filler reactions at the moment, which look very similar.
And or previous, you know, scooping out of these chalazions. So this is a chalazion.
Okay, so I'm going to just go back to the schedule now. All right, so I think this is an important one to do. And then we're going to skip these two papillomas. We do have videos that you can watch about these two because they are relatively low yield. And we are going to go to this one here, the second one.
Mm-hmm.
Right. And then we'll do some corneas. So the next couple that we're going to do are number 5 and the second one under semen.
Okay. All right.
All right, I will stop share and do breakout rooms again. And Michael, I will pop you in room 4. You okay, Charlotte? I think you're frozen there. There we go. Okay, welcome back, everybody. Now we have those two things. Chris, the pathologist, would you like to do the lid margin one? I can share screen.
This one, that's fine.
Share screen.
Ask a few
Schedule.
good questions.
What would you like me to show?
We just concentrated on that middle section,
Yep.
and we'd like to look at either edge. So at the bottom, our team decided that there was skin
Yeah,
with adnexal structures and hair shafts. Occasionally you can get that this appearance near the fornix. And then as we work around to the surface,
sorry.
we saw this very thickened layer of which looks like a tumor with invasive islands, an irregular base, and a deeper lying nodule of tumor. This is a conjunctival surface. If you go to high power, it's very much thickened, the full thickness of the epithelium is involved, and you've got very pleomorphic mitotically active cells with cytoplasmic clearing.
Cytoplasmic clearing.
We couldn't see any intercellular bridges, so we thought that we considered things like melanoma, but we thought it was most likely a sebaceous carcinoma.
Yes, I would agree.
So Chris, do we have to tell them to send it fresh anymore? Like do the oil red O, like in the old textbooks?
No, that technique was actually fraught with inaccuracies, but they can send it paraffin, and we've got a few markers. We can do an adipofilin, and we do a panel of CK7. They're usually CK7 positive. They can have cytoplasmic PAS positive material, and that gives us a good idea that it's a sebaceous origin.
Here's another question. So what about a frozen section then? I see it goes really close to the margin. How about sending it for frozen section? If you think it might be a squamous sebaceous carcinoma. Would you like to receive that, Diane?
No,
Or,
No.
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 Okay.
No, I told them fail if you said that. Yeah,
I
fail.
don't do frozen sections on this. I mean, technically, I mean, with surgery, maybe, but finding that little cell
No.
in that's at the edge is going to be nearly impossible. Mohs is great for BCCs and squamous lesions, but
Not for sebaceous carcinoma. So what should you do instead? Because they creep along the surfaces and it's really hard to tell where they are. So how do you know how to excise the thing if you're not allowed to do a frozen section?
do you think it might be good to map them?
I think mapping biopsies are an excellent idea. So how should the biopsies be sent to the laboratory and what medium?
In formalin.
Formalin.
I
Yes.
thought it was a trick question.
So no special medium required. Formalin is good. So and
Like
then
the
map
way
them.
here it was climbing down the sebaceous gland.
Yes. Or could it have arisen in the sebaceous gland and then gone up to the surface?
Out. And I
Yeah.
quite like looking at the suture material here with the granular reaction.
It means that the surgeons have been there before and taken a previous biopsy, doesn't it?
Okay, yeah.
Here's another question. Why are pigmented lesions contraindicated to frozen section? Do we agree with Matt that we shouldn't send a frozen section for a pigmented lesion?
So if it's a melanoma, it's very hard to get good margins on a frozen section for the in situ bit. Okay.
Mm. Yep. And you're
Um,
going to
Chris-
you're going to ruin your prognostic indices.
Chris and Bridget, do they do Mohs for pigmented lesions in Auckland?
They do them sometimes for flat pigmented lesions on, let's say, the malar skin, but they're really difficult because they're often in a setting of melanocytic hyperplasia, and then you often have to rely on doing a delayed Mohs is possibly more helpful, because
Yeah.
at least you can run a SOX10 on it and see the concentration of melanocytes, because some of them can look extremely bland but be malignant. So I think it's a difficult area.
And then you said run a SOX10. What does that mean, Chris?
Okay, so we've got, well, in our laboratory, we've got a red chromogen, which is chromogen is just the method of staining the cell once we've applied an antibody to it. And then the SOX10 picks up nuclear staining in melanocytes.
Mm-hmm.
And so we get this nice bright red nuclear stain. And it helps us if the cell is very pigmented, because the problem is not all cells that have got pigment in them are melanocytes. Well, first of all, you've got to prove that it's melanin pigment. And if you do a SOX10 and it's positive, then you know that pigment is in a melanocyte. It can, squamous cells can take up passively melanin pigment. So you might have a thing that looks like it's going to be a melanoma, but turns out to be either a pigmented solar keratosis or a pigmented SCC, sometimes even a pigmented basal cell carcinoma.
So, so how long does it take to do a SOX10? Can you do it like in half an hour?
No, it's an overnight, well, probably an overnight stain.
Okay, so just to set your expectations for the turnaround time when immunos are required, you can't really have it the next day.
I know in some places in Auckland, they're doing Mohs for melanocytic lesions, and at the frozen section, they are digitizing their slides, and those slides are being read digitally by a pathologist off-site, but not in our lab. But
no, so that would be the exception rather than the rule.
Yes.
So yeah. Can you do a fat stain on paraffin section tissue? Well, Bridget, can you? Once it's been processed?
Well, we can do immunohistochemistry for sebaceous cells, which can help you, like adipofyllin, that can help. And our PRAME stain works quite well on sebaceous cells.
It does, doesn't it? So
Yeah.
we don't do the oil redo anymore.
No.
That's historical. So we wouldn't call it a fat stain. We would say adipocyte differentiation, I think. Or lipid cell differentiation is how we would call it, Michael.
Okay, should we, Bridget, would you like to comment on this this second slide?
So this second slide, the normal epithelium looks like conjunctival epithelium. Going along the surface, then you get to a part where they look like they're nests of malignant cells within the conjunctival epithelium, and extending down there is this malignant tumor. The tumor is forming a large nodule and is quite a thick tumor. When we look at the tumor cells themselves, they are markedly pleomorphic. Most of them, I think, have an epithelioid configuration with large amounts of cytoplasm, vesicular nuclei, prominent nucleoli. If you can see that on a higher power. In addition, when you look at this, there are multiple mitotic figures, but a little bit of a curveball in this is I haven't seen pigment. So it doesn't seem like there's a lot of pigment, but because of the nests in the overlying conjunctiva that you can see nicely there, and what the tumor cells look like in the underlying tissue, to me, this looks like a malignant melanoma, despite the fact that there is no pigment. In terms of staining, because there's no melanin, you may consider doing a melanocytic immunohistochemical stain like SOX10, Melan A, HMB45. In terms of prognostic markers, it's thick. In an area over the top, the epithelium is lost. It doesn't look like typical ulceration, but I'd be doing some sections for that. I didn't see any vascular or perineural invasion. And I'd also be looking at the margins, and the one margin at the bottom looked a little bit suspect. Yeah.
Would have been much easier if they'd put it out flat though, wouldn't it, Bridget?
It's all curled up. So again, the
We
margin.
keep saying this because it drives us nuts trying to work out the margins on curly.
So sometimes the report will be margin cannot be assessed. Now, how useful is that to you? Not useful at all. So
So this was an amelanotic melanoma showing some pagetoid spread.
what's pagetoid? I thought that was all about breast nipples and breast cancer, Diane. This has nothing to do with that.
He was a prolific man, Dr. Paget, and this is a similar kind of spread to what he described in the breast. Paget's disease, where you get invasion of the epidermis.
From something below.
Yep.
Okay. So
All right.
amelanotic conjunctival melanoma. Is this cutaneous or uveal?
It follows the cutaneous rules. It does. So
we won't do BAP on it then.
Won't do BAP on it. It's UV related. So yeah. Okay, so we're down to here now. I knew that it was too ambitious, today's schedule. I also knew that we had recordings for you to watch for all of it. So I think what we're going to do is just take a moment to do the survey. Yeah.
Now the survey, yes, is this one here in the Google Doc. So I know some of you have got the
let's pop it in the chat.
The Word, so I will drop it into the chat for you because I've made a nice new one so that it doesn't get confused with previous cohorts. Hang on, I've lost the.
You want to stop recording?
Yes, good. Thank you. I'll stop recording.
Okay, there it is, the survey thing. And how many bodies do we have in the room? So we have got, I expect 2,